Alors, notre prochain conférencier, Dr. Ray Lemberg, qui viendra discuter de Eating Disorders Assessment for Men, donc le fameux EDAM dont on a déjà vu un peu, dont on a parlé très brièvement ce matin. Donc, on a la chance de l'avoir avec nous pour venir, pour qu'il vienne nous présenter cet outil de mesure des troubles alimentaires chez les hommes. Dr. Ray Lemberg est psychologue clinicien depuis 1977 en Arizona, au Prescott Mental Health. Il a complété ses études doctorales à l'Université du Maryland. Dr. Lemberg est un pionnier dans le domaine des troubles alimentaires en ayant mis sur pied en 1980 le premier programme d'hospitalisation psychiatrique en Arizona. Il a donné plus de 100 présentations sur le sujet, est rédacteur en chef adjoint d'Eating Disorders de Journal of Treatment and Prevention et est l'auteur de 45 publications. Il a également édité 3 livres sur les troubles alimentaires, dont le tout dernier, Current Findings on Males with Eating Disorders. Alors, il a déclaré un conflit d'intérêts, en fait, qu'il est consultant au Prescott House. Il a été consultant au Prescott House depuis de 2009 à 2015. Donc, accueillons Dr. Lemberg.
Again, it is not. I guess we're on. Thank you. Can everyone hear me okay? All right, good. I'm very pleased and honored to be with you today and to enjoy your most beautiful city and to share important information with you. This is a really exciting time because treatment and diagnosis of men with eating disorders and understanding male issues is extremely new, and we're at the forefront. And my presentation should dovetail with the last presentation with Dr. Stu Murray. And we did not compare presentations, but you'll see a lot of overlap, which is really interesting. And he is pretty much at the beginning of his career, and I'm at the end of my career. I've been with eating disorders for about 40 years. Just happened to chance into treating eating disorders. I want to tell you a little bit about that. I was doing an internship in psychology at Shepherd Pratt Hospital in Baltimore, Maryland, 1973 to 1974. A woman came in and she was bulimic. At that time, the term bulimia was not even used at all. So it was a really good training hospital. My supervisor said, call around the country and see how to treat this because I don't even know anything about this. So I looked in the library first, and there was one book on anorexia nervosa by Hilda Brooke. She was the pioneer. And if you're interested in pursuing the subject, a seminal book of hers is called The Golden Cage, which came later. And then I called around the country. And how many people did I call? One. There was only one publication. It was a New York psychiatrist, and he was treating bulimia with anticonvulsant therapy. And I don't think very successfully, although if you look at some of the treatment to block binge cravings, Topamax is one of the anticonvulsants that is currently being used. So he may not have been too far off. So I finished my training at Maryland, went back to Arizona where I'm from, worked at a community mental health center, And this is 1977, and women were steadily coming in with anorexia and bulimia. And the whole staff of the mental health center was afraid to treat these people that could die on them. So, of course, I volunteered because I knew nothing about it. I treated one woman unsuccessfully. And then I quickly went through the ranks and became a psychiatric hospital administrator within 5 years, and had the opportunity to develop the first eating disorder program in Arizona in 1980. So I just kind of chanced into the field. And since then, I've been interested, publishing. I've been in private practice for 38 years and treating eating disorders and consulting and publishing. So you're getting kind of the historical view. What Stu gave you was really an up-to-date view of what's going on in the field, and that's why I say it's a very exciting time. This is cutting edge. So I was at the cutting edge 40 years ago, and you all are at the cutting edge of what's going on with boys and men with muscle dysmorphia and disordered eating. I'm going to tell you about this inventory that is in the process of being developed. And anyone that wants to use it, at the end of the presentation, there will be information on how you can access the inventory. It is not fully researched. It is still being researched. We have some more factor analyses to do, but it is still useful. It is not a fully developed diagnostic tool, but it is useful in identifying some of the issues for males, and you're welcome to use it. The reason for the inventory was that I was consulting locally in Arizona to a treatment center called the Prescott House, residential treatment center, long-term, 9 months, for males with addictions. And what we were finding was that more and more of these men, now this is going back about 8 years, had a comorbid eating disorder. They weren't volunteering the information, but we were starting to ask. And that's what has happened throughout the U.S., and I believe so in Canada as well, that more awareness is there. So more clinicians, more treatment centers are beginning to ask if there are some issues with body dysmorphia and with disordered eating. So we began to ask, and we found that there were quite a few men that had comorbid eating disorders along with an addiction. And the big addiction that we're seeing right now is opioid addiction. So in my career of 40 or so years, I have either seen personally or consulted to different hospitals and treatment centers about 3,000 or so women with eating disorders. In my private practice, how many would you guess have come forth to seek treatment? 10. 10 males. Been underdiagnosed and undertreated, and we're just starting to get there now. So I decided we needed an instrument to identify males with eating disorders. One specifically for eating disorders does not exist. There's some on muscle dysmorphia, which we'll talk about in just a moment. But this is a brand new instrument, and there's much need to research it. One of the questions that was asked in the previous seminar was kind of how do you stay current with the sociocultural influences on body image and appearance and the pressures on men and women, because the symptoms of eating disorders are going to continue to change, and we need to keep updating these instruments and our knowledge base. And someone also mentioned that the multidisciplinary approach is really important, which I would endorse wholeheartedly. It's always been important. So that's a little bit of background. And let's see. Let's go to the first slide. So can you read this in the back, or should I read it? You're okay? Yeah? okay. Anorexic Cafe now closed 24 hours a day. Kind of morbid. Okay, for anorexia. So we know that currently it is estimated that 1 in 5 men show signs of anorexia, which is a huge increase over the last 15, 20 years. Huge increase. What we also know is that of all of our psychological diagnoses, and for those of you in the field, whether it's clinical social work, psychiatric nursing, psychiatry, psychology, whatever it is, you know that in our DSM manual, psychologists, psychiatrists, the rest of us, we're really label happy. We love labels. We have labels for everything. Of all of our labels, anorexia nervosa is highest on mortality. Highest of all of our diagnoses. Superior or above major depression. So about 5 to 10% of those with anorexia, I'm not just talking about males, the total population, has a mortality rate, 5 to 10% die or are killed from that disorder. About half because of the biological effects of starvation, electrolyte imbalance, if they're purging, stops the heart, and just the effects of starvation. The other half, suicide. So it's really an alarming disorder. Oh. Don't step on it, it makes you cry. And of course, women, the majority of this audience, know this more than men. The pressures to be appearance conscious, to be thin. Just, in Western society, we've just done a terrible disservice to women. But we're getting more, we're not discriminating. We're getting more equal opportunity. We're now doing it to men. So this is a great thing that we're evening out the playing field and hurting male body image as well as female. Okay, why the need for a specific instrument? So I want to talk about some of the differences between genders. Males are, on the whole, so I'm generalizing, much more self-conscious of upper body. We've talked about muscularity, abdominal development. Women are much more self-conscious in general of lower body, butt, hips, thighs. One of the reasons for the need of an instrument is that the most popular instrument in the world is the EDI, Eating Disorder Inventory. It's the 3rd edition, but it's really normed mostly for women, and it has questions like, I am concerned about the size of my hips. You don't get much response from men on those kind of questions. That's why we developed this instrument. Women, there is even more drive for thinness, although it's there in more men these days. And compensatory mechanisms. So this is purging, compensating for binge eating. Compensatory mechanisms, well, for men, it's overexercise by far, much more prevalent. Females are more likely to use laxatives or to purge by vomiting. Not to say that males do not do that, but it's more common. Exercise strategies. As I said, men are much more likely to compensate with exercise, and I'll reinforce what was just said before the break. It's incredible how many men that are compulsively exercising to change their body image, to create a sense of self, external sense of self that allows them to feel in control, that allows them to have more self-worth by externalizing, by creating muscles. It's amazing how many men will exercise when they're injured, will exercise when they are sick and have the flu. We see this in the treatment centers all the time. Steroid abuse, of course, we've talked about that. Much more common in men than in women, as well as use of human growth hormone and all kinds of over-the-counter supplements that probably either do not do anything or are possibly harmful, kind of a placebo for a lot of men. And then underlying dynamics, and this is something that I've used over the years. I like to use the 3 Ps. Predisposing factors, precipitating factors, and perpetuating factors. And those of you that are students of psychology in some way or another, that's an important concept to hold on to. Predisposing, precipitating, and perpetuating. So if you want to understand a disorder, consider all 3 of those factors. So some of the predisposing factors for males are, well, there's a genetic history that supports or that produces high internal nervous system arousal. Basically, it's the same as anxiety. So these men tend to be more prone, as women, to more anxiety, compulsiveness, perfectionism in their genetic histories. Also, there's more men that have a history in their families of obesity. So some eating disorders are produced by trying to fight off this morbid obesity. And I'll just insert something else that's really interesting, is that the men that are bulimic, this is not so much about muscle dysmorphia, but men that are bulimic, that binge and then purge to compensate, and I view it as they release, meaning that they binge, and it's a way to deal with anxiety, to self-medicate anxiety. We know that binge loads are carbohydrate, sugar loads that raise tryptophan, that then raise serotonin. So it's a way of self-medicating. It's a feel-good drug, binging. And then that's the release, letting go, and then restricting, trying to compensate for the binge, either by starvation or purging. So what's interesting is that women, and this, I'm generalizing, in terms of predisposing factors, often, more often than not, believe that they are overweight when they're not, when they start dieting. And men actually have a history of being overweight. So women have this perception that they are when they're not, and some subpopulation of the males with bulimia have had a history of being overweight, and then they start dieting. All right, precipitating factors. Trauma for women, sexual trauma is very common. For men, bullying is more common. So trauma that hurts self-esteem. For women, sexual abuse can result sometimes in anorexia, trying to disappear, not be a feminine, not have a feminine physique. So just literally to wither away, or to gain weight and to be heavy and not sexually attractive, or a potential victim. And for men, bullying is more common, both of which, of course, injure or assault the self-esteem. And then if you think about dieting or control, binging and release and then restrict, it's a way of establishing some control over self. It's establishing, and then if you have appearance ideal that you're seeking, it's a way of establishing route to self-esteem or self-worth. So it's an external rather than an internal way of establishing core self-esteem. Dieting. Dieting is a precipitating factor. Why is dieting a precipitating factor? Well, aside from watching what you eat, looking at good nutrition, watching your diet in terms of meal planning, aside from that, any kind of rapid weight loss is unnatural. It deregulates the body. So dieting is a precipitating factor. I don't know, I wasn't here all day yesterday. Did anyone talk about the Keys study? Does that ring a bell? Keys study? Okay. I'm a little rusty on this. I hope I quote this correctly or close. At the end of World War II, in the U.S., there was concern, what would happen if we did not get food, rations to the troops on the front line? How long could they last? How long could they think clearly? How long could they function? So they did a starvation study by a gentleman by the name of Keys. They recruited about 20-year-old guys. They were conscientious objectors. They didn't go to war. They lived in a camp, and for 3 months they measured their caloric intake. And then for, I believe it was 6 months, this is the part I'm a little rusty on, they starved these men half ration. And then the last 3 months they refed them. So what did they find? Well, weight loss, of course, right? I mean, that's obvious. But one thing that they found back then, and we're talking about over 50 years ago, over 60 years ago, is that weight loss was not a steady decline, that the body fights to keep alive. So it would plateau, and then you lose more weight, which anyone that has dieted knows that. So that was new information. But psychosocially, what did they find? And this part is what's really interesting. 20-year-old American males, mid-40s, 1940s, when their wives or girlfriends came to visit them at the camp, they lost interest, social and sexual interest. What were they interested in, do you think? Cooking, recipes, food, obsessive. The brain got brain locked because of starvation. These were not intentional dieters, but look what happens physiologically when the brain is starving. It gets brain locked. They would hoard food. They would cut food into small pieces, savor food, cut out recipes, look at recipes. This was not the typical 1945 American male, 20-year-old male. So the brain gets locked. So that's part of why it's been so hard to treat people with anorexia. And I've had, over the years, several patients die. Put them in the hospital, refeed them. And for some, this is not too important, but a small subset of people that are refed become hypercaloric. One woman that I treated, probably about 22 years of age, 80-some pounds, she didn't start to gain weight until she was up to 2,800 calories a day. The body just started burning it. In literature, there's a case study, but there's a number of them. One woman, before she could gain back her weight, needed 9,000 calories per day. How do you sustain that when you're out of the hospital? Because we'd have people on tube feeding during the night, and then they'd eat during the day, and then they'd go and they regain their weight, but they wouldn't be mentally cured of the obsessive compulsiveness. They go home and they die. And because of, it's a different system here in Canada, but because of our insurance system, you can only admit people for so long and keep them for so long. So perpetuating factors are people sometimes develop a anorexic, bulimic, muscle dysmorphia identity. That's their whole life. And it perpetuates. It's so hard for them to give that up. And that's why a multidisciplinary team is needed if you can get them proper treatment, because there's so many different angles to assist them to get better. But they're just really locked on to the disorder. Then in males, they're underdiagnosed, underserved, undertreated. So a perpetuating factor for boys and men is that they don't get recognized and in treatment, or they don't come forth because of the stigma that this is a women's disease. All right, incidents. So we've talked about media pressure. It's skyrocketed, especially in the last 15 years, and it goes back beyond that. Estimated as many as 1 in 4 of those with an eating disorder are men. And when I last edited a book on eating disorders about 12, 14 years ago, it was estimated, and this has been said, was estimated that 1 in 10 men had an eating disorder of some kind. Now it seems to be 1 in 4. And in Saskatchewan, there was a study, I don't have the reference, it was estimated to be 1 in 3. That's a recent study. Regarding recovery, it takes the average person with anorexia 8 years of treatment to recover, average woman, average man, which is 1/3 longer than it takes for the average woman to recover. Maybe just be that we have inadequate treatment methods at this point because it is so new. Okay, here's a case example. I'm a 13-year-old male. I used to have a six-pack when I was 11. Since then, I lost it. I still have muscle, but it seems fat. But buried underneath about a centimeter of fat. Okay, I just destroyed that. But it seems buried under about a centimeter of fat. I can pinch about 1.2 inches under my belly button. I'm fat, but I need help to lose weight. Another one. I'm 50 years old, and every night I sneak into my kitchen and eat tons of food like bread, cake, cookies, sticks of butter, and anything else I can get my hands on. I can't stop. And then I stick my finger down my throat and puke it up. I don't know if I'm the only guy who does it. I know lots of girls who do it. Am I crazy? Changes in the media. The male body in advertising, especially the muscled male body, the undressed male body, is worth billions of dollars. Men's bodies are used in every way to advertise products totally unrelated to the body. A lot of this started with Calvin Klein way back. This is a commercial for the watch, Swatch. This is a mock commercial for Sex and the City to Absolute vodka. It says Absolute Hunk. All right, so this is Michelangelo's David in 1504. This is Charles Atlas in 1935. And this is the World Bodybuilding Champ of 2009. That's really pretty. Jeez. Reminds me of the last presentation of that guy that was eating the eggs and sardine. I could not handle that. I don't have a squeamish stomach either, but anyway. Okay, body image pressure increasingly affects boys. This is what we've been talking about. Excessively thin male models in the media. Prevalence. So, as I said before, many more men are being identified in treatment centers because we're now aware to look for it. And it's still early, but the stigma for men is still there. It's still seen as a women's disorder, although beginning to decline. And that's why this kind of seminar is so important. Body image isn't just a girl's thing. Boys suffer too. Okay, so here are some existing diagnostic tools, and none are directly related to the eating disorder portion. They're related mostly to body dysmorphism, which is very important. So there's some of the existing tools. So here's what we did. So I said I was consulting to this residential treatment facility, Prescott House, and couldn't find an eating disorder instrument for males. Recruited a doctoral student at Northern Arizona University. Her name is Stevie Stanford. She did her doctoral dissertation to develop this instrument. So she was the chief investigator. So let me tell you a little bit about instrument development, which I'm sure you all want to know how to develop an instrument. You're just dying to do that, but okay, I'll go through it pretty quickly. All right, the first step is that we looked at the major categories of symptoms, so the conceptual underpinnings. Weight concerns, food preoccupation, body image and other appearance issues, and disordered eating practices. Disordered eating practices meaning ways to compensate, purging, overexercise, ways to diet, to restrict. So we generated potential items, over 100 items on a 5-point Likert scale. Likert scale goes from almost always to almost never, with 5 discriminations. Then we developed a list of key informats. So people internationally who are in this field, we gave them our 100 and so items and said, please rate them from 1 to 3, unacceptable, fair to good. Then we eliminated items just based on consensus. Then they were tested on our population at the Prescott House. We gave the instrument to men who were known to have an eating disorder plus an addiction, and men that only had an addiction. We wanted to look at what discriminated between the two groups. Then we eliminated items and refined the questionnaire, which resulted in 50 final items. We're still studying those and wanting to refine them further. So here's some of the, here's a little bit more on the study. So 108 people participated, men and women, from several hospitals throughout the U.S. A large percentage were Caucasian with a median level of education of some college. They were given both our instrument, which is called the EDAM, Eating Disorder Assessment for Males, and the Eating Disorder Inventory 3 for comparison. Remember, the 3 is developed for women and is not adequate for men. But we wanted to see how they responded to both. And then we presented our instrument, the EDAM, as we called it the Health, Fitness, and Eating Habits Survey. So why disguise it? Why not say this is eating disorders for men? Well, we wanted to avoid response bias, although, to an extent you can see through it. You can see what it's all about. But this is how we titled it. And we did multiple analyses of all kinds. These were the final 4 scales. Binge eating, muscle dysmorphia, body dissatisfaction. So body dissatisfaction includes not just men wanting more muscle, but just not accepting their overall appearance, and for many, drive for thinness. So the point was made that to develop muscle, you also have to reduce fat. So the diets often are very high protein, low carb, and then a lot of excess over exercise. And then eating disorder behavior, which is the specific symptoms that involve disordered eating. So here are some examples of questions. Under binge eating disorder, I show self-control when it comes to food. And again, they're checking a 5-point scale. I find myself eating very quickly, so one of the aspects of binge eating or bulimia is eating massive amounts of food in a very short time, not eating for hunger, eating for emotion. And I feel as if I cannot stop eating once I start. So feeling out of control. Muscle dysmorphia. I think about gaining more muscle. I get enough exercise. I check my body several times a day for muscularity. Body dissatisfaction. I weigh myself many times a day. When compared to bodies shown in the media, I feel inadequate. And there have been a bunch of studies now that, and one was referenced in the last talk, about how media influences body image, but it can be done in a study of an hour where boys are given muscular bodies and then asked to rate their own body or their own body satisfaction, which goes down. And I should say about the media, it's not the cause of eating disorders, it fuels eating disorders. So it's one of the contributors, but it really fuels unhappiness with one's body. I check my body several times a day for fatness. Eating disorder behaviors. The urge to vomit after eating is overwhelming. I've used over-the-counter diet pills. I feel the need to cut my food into small pieces. So those are the examples. There's 50 items in total on the EDAM. If you want to use it, keep in mind it's still in its research development stage. It doesn't provide a definitive diagnosis. It's a tool to identify what the target concerns are. And this is important. If you'd like to use the EDAM, contact Stevie Stanford at yahoo.com. But the important thing that's left out of here is that you just want Stevie underline Stanford. So there's an underline between Stevie and Stanford at yahoo.com to get her correct email. And she'll send it to you. We have a whole scoring guide that's easy to score, easy to use. It takes 10 minutes or less. And then here's my email if you want additional information. So, summary. So obviously eating disorders among men is not just a female problem. It's difficult to detect and treat because unless the person's anorexic, they may have a healthy physique and yet they have disordered eating and they're not doing healthy behaviors. And there's continues to be the stigma attached. So many men, boys and men, don't come forward thinking, don't even recognize that they have an eating disorder. This is not a men's problem. This must be just kind of an anomaly. They go to their physician, if they do recognize it, and the physician in the past says, just eat better. They don't recognize they have an eating disorder because it hasn't been disseminated. So it goes untreated. All right, so questions? Thank you.
Hi, thanks for that. I'm just a little bit confused because I don't do a lot of quantitative work. Is it one scale with 4 subscales?
It is. It's one scale with 4 subscales.
Okay.
And it alternates with those 50 questions. Every other question is on the different scale.
Okay, and how have you used it so far? Have you used it to correlate with various things?
Well, we've used it in our treatment setting at this residential program to identify what is really the key issue with that man with the eating disorder. What's he most concerned with? So it's been used that way. When it's at a further stage of development, we believe that it'll be a true diagnostic tool.
Hi, I'm Cora, a dietitian. I have a question about your questions on muscle dysmorphia because I get enough exercise within a 1 to 5 feels really confusing to me. Is there more questions? Are there more questions about the enough exercise? Because if I consider enough exercise 2 hours a day versus someone else.
So there's 50 questions. That's just a sample. So there's about 12, 13 questions on muscle dysmorphia on each of those sections.
But is there a quantified amount of exercise in any of the other questions? Because I feel like that would be really
To be honest, it's been a while since I've looked at the scale. I'm sure there's some better questions, but I honestly don't know.
Okay, thank you.
Anything else?
Hi, thank you for your presentation. Laurence, I'm a student in psychology. I was wondering if you noticed any challenges in the evaluation or the assessment of eating disorders, particularly for men.
So I didn't hear all of that. Did you hear it?
Can you hear me now?
No.
Okay, I'll try to speak louder.
Okay, that helps.
I was wondering if through your research you were able to see some challenges for the assessment of eating disorders for men compared to women.
Can you be more specific? Any kind of challenges that you're thinking about?
Well, in a matter of, for example, as a questionnaire in order to diagnose, for example, eating disorders according to men. So maybe in choosing the items also in the questionnaire.
Everything at this point, it's a good question, everything at this point actually is a challenge because even though some of the presentations have overlapped and you can see that we're starting to really hone in on some of the variables that contribute to eating disorders, this is such a new landscape that we have to navigate. The whole idea of muscle dysmorphia, I think, eventually is going to be teased out from eating disorders and seen as a separate kind of, involving some disordered eating, but a separate kind of syndrome. And so everything is really brand new in trying to figure out what to measure. It is a great challenge, and that's why we need more research. The instrument is just really basic at this point. Any other questions?
Oh yeah. Psychiatrist, physician. I'm just wondering if you thought about adding some validating scales in your instrument, like to see if the person is not. It's kind of paradoxical because the eating disorder, the person tends to not overwhelm. Have a sense of an age that is over or less, but when we do psychometric testing, sometimes we tend to over answer to project a better ideal of ourselves or a lower ideal of ourselves because we tend to restrain our answers. So do you find that it will be helpful to add those validating scales?
I don't know if everyone heard that, but will we have scales that are really to validate, is this, in psychometrics, we look for two major things, typically. One, is there over-reporting? Does a person have any kind of motivation to exaggerate? And we also look at under-reporting. Do they have any incentive to minimize? And a lot of times, like with a physician, they may be, there may be stigma, they may be embarrassed, so they tend to minimize symptoms. It happens a lot with drug and alcohol use, so the primary care practitioner has a hard time really getting a handle on, I drink in moderation. Well, what's moderation? And unless you ask, and unless the person's truthful, you don't know. So it will need validity scales. It's a really important point. Stu?
Hi, Ray. Can you hear me?
Yeah.
That was a great presentation. I really enjoyed it.
Thank you.
I just wanted to ask a question kind of related to the previous question about scales for convergent and divergent validity, and whether you guys have thought about integrating any scales to sort of, illustrate convergent versus divergent validity.
As I said, we're not at that stage of the research, but yes, indeed. Validity scales, I think, are really important. So we need to have scales that correlate with external correlates of validity, real-life behaviors, other scales, and so forth.
I saw in your slides that with the participant, you gave the EDI tree with your questionnaire?
We did.
Yeah, and do you have the chance to compare the results or to
Right, so the question is, we gave the eating disorder inventory 3 along with our questionnaire, and we did do analyses on the results, and there's some of it was, the EDI 3 did a good job in some areas, but not some in other areas specific to male concerns. So it helped us to differentiate what are more female and what are more male concerns. Hmm.